Our first speaker is Dr. Manasa. Dr. Manasa is working as a cataract surgeon at PRS Hospital and at Geetanjali Hospital in Trivandrum. And today she'll be speaking on the topic navigating cataract surgery with concurrent medical conditions. Over to you, Dr. Manasa.
Thank you, ma'am, for the introduction. Good morning, respected seniors and dear colleagues. So let's see how we maintain our perioperative checklist in patients with systemic comorbidities. So the recommendations in the presentation are sourced from the following professional bodies. Now, cataract surgery is an entirely elective procedure. So why can't we just postpone the surgery until the patient recovers systemically? So this statement is neither absolutely true or false, and how do we decide on that? So most of our patients are elderly, and many of the systemic conditions can't be fixed easily. And there is a lot of evidence that suggests that waiting for more than 4 months after a cataract surgery is clearly indicated is associated with an increased risk of mortality. As we all know, visual impairment affects the quality of life, increases the risk of fall and fractures, increased hospitalization, nursing home placements, social isolation dependency, and visual and cognitive impairment, and a generalized increase in higher mortality. So let's see a few case scenarios. This first one is about a 57-year-old gentleman with stage 5 chronic kidney disease who underwent a recent renal transplantation, and he's on dual antiplatelets and anticoagulants for a graft renal artery thrombosis. Preoperatively, his blood pressure was 180 by 100. A medical clearance was obtained, and he was posted for clear corneal phacoemulsification under topical without stopping any of his medications. Intraoperatively, he had a high blood pressure for which a short-acting vasoactive was given, and there was a period of postoperative hypotension. Now let us see what the recommendations say to manage such a case. Regarding hypertension, the recommendations suggest we postpone the elective cataract surgery only if the blood pressure is more than 180 by 110, and in cases of malignant hypertension where there is evidence of target organ damage. And there is no recommendation that suggests that we should record the blood pressure on the day of surgery, because that will be mostly erratic due to anxiety. And if we give a hypotensive agent based on that blood pressure reading, most likely the patient will go to hypotension, and a mean arterial pressure less than 65 for a longer time has a higher risk of myocardial and kidney injury. Now coming to the recommendations on oral antiplatelets and anticoagulants, we can continue dual antiplatelet therapy and all the oral anticoagulants and the vitamin K antagonist, as long as we are planning for a clear corneal phaco under topical or subtenon block. But we should avoid sharp needle blocks in these patients. And if you are planning to block, we have to stop the drug based on the duration of action of that drug. And a routine heparin bridging is no longer recommended. And the second case scenario is about a 77-year-old gentleman with a host of systemic comorbidities and 2 episodes of anaphylaxis following attempted cataract surgery. He also has a non-healing ulcer in the right leg. So the first episode was following application of moxifloxacin and nepafenac on the day before the scheduled surgery, following which he developed respiratory distress and required an ICU admission. The second episode was after application of dilating drops, again similar ICU admission and treatment for anaphylaxis. So at this presentation, the allergy and immunology department has advised us to instill topical medication only in a setting with resuscitative facilities, and they also deferred an intradermal allergy testing due to the severe risk of anaphylaxis. So in patients with multiple drug allergy, that is to multiple topical medication, it is most likely to the preservative in the medication than the primary drug. Nevertheless, we should avoid all previously implicated drugs, and we should use preservative-free medication and avoid preoperative topicals. Consider a no-drop protocol wherever possible. Use an intracameral preservative-free dilating cocktail, or we can resort to mechanical dilatation, and we have to perform the surgery only in a fully monitored setting in the presence of an anesthetist, a crash cart, IV epinephrine, and we have to secure an IV line preoperatively in all these patients. And the second part of the case, where the patient had a chronic leg ulcer. Now, all the recommendations suggest we have to defer the elective cataract surgery when infections outside the eye exist to reduce the risk of postoperative endophthalmitis. But we should also keep in mind that many chronic low-level infection like an ulcer or a UTI may not be self-limiting and cannot be easily treated, and many of these ulcers are not even infected. So if we are going ahead with the surgery in the best interest of the patient, a thorough counseling has to be done and a high-risk consent to potential additional risk has to be taken. The third scenario is about an elderly female with complete heart block, a permanent pacemaker in situ, with a recent history of CAD, and she's an uncontrolled diabetic. Let's see what the recommendations say for such a case. Regarding the cardiac implantable electronic devices, there are multiple such devices, of which the pacemakers are what we encounter commonly. In phacoemulsification, we don't use diathermy, so a CIED malfunction is extremely low. And if a diathermy is used, it can result in malfunctioning of these devices, resulting in loss of cardiac output, life-threatening arrhythmias, and even death. And regarding pacemakers, no reprogramming is needed for clear corneal phaco without cautery. Now, coming to the recommendations regarding diabetic patients, none of the recommendations say that we have to measure the preoperative HbA1c or a preoperative point of blood sugar measurements on the day of surgery, as long as the patient is not unwell, he has not skipped any meals, or he has not skipped any medication. And we can continue all the oral hypoglycemic and insulin, as we are not asking the patient to come NPO. Maybe we can consider stopping the SGLT2 inhibitors, because under stress, it can precipitate a euglycemic diabetic ketoacidosis, which we miss if we don't measure urine ketones. And the third part of the scenario, the recent cardiovascular problem. So the American College of Cardiology and the American Heart Association recommends that if the patient has underwent a percutaneous coronary intervention without a stent, a non-cardiac surgery can be scheduled after 2 weeks. And if it is a bare metallic stent, that is not a drug-eluting one, then we have to wait for a month. And if a drug-eluting stent is implanted, then we have to wait for 3 months for a non-cardiac surgery. And the final case is just a reminder where zero is never a statistical option. A perioperative mortality risk exists even after our low-risk eye surgeries. A 72-year-old female, only known hypertensive, and we plan for a combined right phacoemulsification with pars plana vitrectomy for a macular hole repair. In the perioperative period, she develops loss of consciousness, was brought to the ER, multiple episodes of ventricular fibrillation happens. After multiple cycles of CPR, return of spontaneous circulation was achieved. A coronary angiogram was done, was normal to rule out CAD. MR brain was normal, that rules out stroke. So even on the way to ICU transfer, she gets multiple ventricular fibrillation. And again, many ECGs were taken and reviewed. And finally, she was diagnosed to have Brugada syndrome, which is an occult cardiac channelopathy, where we get a particular kind of wave only in V1 to V3 leads, and that too in a few ECG. Unfortunately, we lost the patient. So this is a reminder that even when eye surgeries have minimal physiological stress and there is no blood loss or fluid shift, a risk of mortality of 0.014% exists, and it is unlikely that this risk can be further lowered. So when to defer to allow the optimization of these comorbidities? So as we discussed a recent CAD, significant arrhythmias, heart failure, acute pulmonary neurological condition, malignant hypertension, and decay. These are what the recommendations suggest. And what are the preoperative tests recommended? Actually none. Not even an ECG or a urine routine examination is recommended for patients who are asymptomatic, but we should carefully document their medication history, allergy history, and the systemic illness history. Now, how long does a preoperative medical assessment is valid? There is no specific time cutoff, as long as the health status, medication, and the allergies is not changed. But it's better to aim to schedule the surgery for a few weeks after the assessment and not more than 3 months. And which cases we need an anesthesia colleague? Only in grade 4 ASA patients, that is where we defer the surgeries. And if optimization is not possible, then we proceed in the best interest of the patient in the presence of the anesthetist. And of course, if you're planning for GA or IV sedation. So the take-home message is, regardless of the elective nature of cataract surgery or the severity of the systemic comorbidities, the decision and the timing of the surgery should be based on the patient's best interest. The guidelines and recommendations helps reduce unnecessary preoperative cancellations. Thank you.
Thank you, Dr. Manasa. It's actually a very relevant topic because most of our patients are quite elderly. They have multiple systemic comorbidities. And this particular case that she spoke about, Brugada syndrome, actually that patient developed this cardiac event. One of the factors that was proposed was that the patient had to be in a prone position. So that might have been a stress for the patient to develop the VF actually. So we still don't know because even the bystanders and all of us were a little surprised because she was a healthy patient and post surgery she had this event. Thank you, Dr.